Thank you. Hello, I am Jennifer Watkins with the NHSN Protocol and Training Team. Welcome to the 2024 NHSN Annual Training presentation for pneumonia or new surveillance. I just want to mention first that in addition to the handout for this presentation that's located on the conference website, there's also an additional handout in the swag bag in the Resource Center that contains a list of acronyms that may be used during this presentation, as well as some information that will be helpful for the pneumonia case studies. I'm going to go off video now, so I'm not distracting all of you through the rest of the presentation. Let's start by reviewing today's learning objectives. At the conclusion of this presentation, you should be able to do the following. Describe the 3 pneumonia algorithms and the requirements for each. Determine what imaging findings are eligible for meeting a new definition. Identify eligible signs, symptoms, and laboratory findings for meeting a new definition, and apply the new definitions correctly to case scenarios. And now let's get started with the presentation. The first step to performing new surveillance is to locate the new specific resources. The new events webpage can be accessed from the left navigation bar located on all of the NHSN web pages under the heading Patient Safety Component. The new web page has links to resources necessary for conducting new surveillance. A few highlights are the new protocol, the new training page and educational roadmap, and the new FAQs. I highly recommend you review the new FAQs. They provide additional guidance for applying some of the concepts of pneumonia surveillance, and you may find answers to some of your questions there. Also, the new event and denominator collection forms and tables of instructions are located a bit further down the page. They also contain information necessary for accurate data collection. Take the time to become familiar with the new web page and the materials provided, as they are important for understanding and applying the new surveillance definition. The NHSN pneumonia, or new protocol, is Chapter 6 in the NHSN Patient Safety Component Manual and can be accessed from the new event webpage or directly from the link provided. You may find it helpful to refer to the new protocol during this presentation. So when and where can you conduct NHSN new surveillance? New surveillance is only available for in-plan reporting from mechanically ventilated patients in pediatric locations. However, new surveillance can be performed off-plan for any patient, regardless of age, location, or ventilation status. And the new definition is available for secondary BSI assignment for all patients. Now let's take a look at how the new definition can be met. The new surveillance definition can be met with any of the 3 algorithms, new 1, new 2, or new 3. When you meet new 1, new 2, or new 3, this is reported as a new event. Regardless of the specific event, new 1 or new 2 or new 3, you must first meet the imaging element, and then you must meet the signs and symptoms element. And in the case of new 2 and new 3, you must also meet the laboratory element. Additionally, there are footnotes in the algorithms that provide additional information and guidance for meeting the elements. The information in the footnotes must be incorporated into the decision-making process for determining if a new definition is met. Let's take a look at the 3 algorithms. New 1, which is located in Table 1 in the new chapter, is clinically defined, meaning there is no laboratory test evidence required to meet the definition. Required elements in the infection window period, or IWP, include imaging test evidence and signs and symptoms. There are 3 sets of criteria for new 1 signs and symptoms. First is any patient, which can be applied to patients of any age, including infants and children. There is an alternative criteria that can be applied only to infants less than or equal to 1 year old, and also an alternative criteria that can be applied only to children greater than 1 year or less than or equal to 12 years old. The age-specific alternative criteria for signs and symptoms only apply to new 1. You can't use the signs and symptoms from the alternative criteria for infants or children to meet new 2 or new 3. And we'll explore the age-specific criteria more in depth when we cover the signs and symptoms component. New 2 is located in tables 2 and 3 and includes laboratory test evidence in addition to imaging test evidence and signs and symptoms. Required elements in the IWP include imaging test evidence, signs and symptoms, and laboratory evidence as defined in the laboratory column of the algorithm. There are no age-specific criteria. The same signs and symptoms requirements apply to patients of all ages. Remember, you can't use the age-specific signs and symptoms from new 1 to meet new 2. New 3, which is located in table 4, can only be applied to patients who meet the new immunocompromised definition in footnote number 10 in the new protocol. And we'll cover this later in the presentation. Required elements in the IWP include imaging test evidence, signs and symptoms, and laboratory evidence as defined in the laboratory column of the algorithm. Additionally, the patient must meet the new immunocompromised definition in footnote number 10 in order to apply the new 3 algorithm. Again, there are no age-specific criteria. The same signs and symptoms requirements and immunocompromised requirements apply to patients of all ages. When applying the new definition, remember, although there are specific criteria which can only be applied to infants, children, or immunocompromised patients, these patients can meet any of the other criteria. For example, an infant can meet new 1 any patient, new 2, or new 3 criteria, and an immunocompromised patient can meet new 1 or new 2. When reporting a new event, there is a hierarchy for reporting if more than 1 new event is met during the IWP or the RIT. The reason for the reporting hierarchy is that pathogens cannot be reported for new 1 events in the NHSN application. So in order to report pathogens for a new event, you must upgrade the event in the application to new 2 or new 3. And here's our first knowledge check. Remember to place your answer in the chat. Which new algorithm doesn't require laboratory evidence? A, new 1, B, new 2, or C, new 3?
Jennifer, I'm seeing mostly A's at this point.
Excellent. The correct answer is A, new 1. New 1 does not require laboratory evidence to be met. However, new 2 and new 3 do require laboratory evidence as defined in the laboratory column of the algorithms. Let's move on to imaging test evidence. Imaging test evidence of pneumonia is a main component of the new surveillance definition. If the imaging component is not met, the new definition cannot be met. Determining if the imaging test results meet the imaging requirement is the most challenging part of new surveillance. Here's a screenshot of imaging test evidence from the algorithm. We'll look at this more in depth in the next few slides, but I want to highlight a few things first. The imaging test evidence requirements is the same for all 3 of the new algorithms. And unlike imaging for other NHSN events, the imaging findings for new must be new or progressive, and they must be persistent. Definitive findings for new are listed: infiltrate, consolidation, cavitation, and for infants less than or equal to 1 year old, nematoceles. And again, don't forget the footnotes. The information in the footnotes must be applied when determining if the imaging requirement is met. Let's break down the imaging requirement. First, the eligible imaging findings around the time you are trying to meet a new definition must be new or progressive, and the eligible findings must be persistent. Pneumonia may have rapid onset and progression, but it does not resolve quickly. Rapid imaging resolution suggests that the patient does not have pneumonia, but rather a non-infectious process such as atelectasis or congestive heart failure. What do we mean by new or progressive? A finding is considered new if it was not present in the prior imaging test. For example, if there is an imaging report with no findings of pneumonia, such as lungs are clear or no acute cardiopulmonary process noted, and the next imaging report has findings of, for example, new consolidation or interval development of infiltrates, this would be considered a new finding since it was not present in the prior imaging. A finding is considered progressive if the findings are worse in comparison to the prior imaging test. If the language in the imaging report supports that the imaging findings are progressive or worsening in comparison to findings in the prior imaging test, for example, increasing infiltrates or worsening consolidation, we would consider these findings to be progressive. And please note, we don't require the clinicians to specifically use the words new or progressive in the imaging reports. If the language in the imaging report is consistent with these keywords, we consider the new or progressive element to be met. Now let's talk about persistence. It is likely a patient will have multiple imaging tests performed, and for all patients, all temporally related imaging findings must be assessed to determine if the imaging requirement for persistence is met. If the language in the imaging reports supports that the imaging findings are persistent, for example, infiltrates persist or consolidation is similar to prior imaging, we would consider these findings to be persistent. For patients with underlying cardiac or pulmonary disease, serial imaging, that is, 2 or more imaging tests performed on separate occasions, is required to demonstrate that the imaging findings are due to pneumonia and not a reflection of the underlying disease process. And since persistence is a requirement for all patients, if multiple imaging tests are available, they must be assessed for persistence of findings of pneumonia. However, there is an exception. In instances where only one imaging test is available, it can be used to satisfy the imaging requirements in the following situations only. For all patients for POA determinations, that is for new events with a date of event in the POA timeframe, and for patients without underlying cardiac or pulmonary disease when no other imaging tests are available. But remember, for all patients, regardless of underlying disease, if multiple imaging tests are available, they must be assessed for persistence of findings of pneumonia. And this is just a screenshot of footnote number 1, which provides guidance about the persistence requirement. So what findings are eligible for meeting the imaging component? Eligible findings include the definitive findings listed in the new algorithm, infiltrate, consolidation, cavitation, and nematoceles for infants less than or equal to 1 year old, as well as certain alternative findings as discussed in footnote number 2. These alternative findings include opacities, airspace disease, and densities. But it is important to remember that if these alternative findings are attributed to a process other than pneumonia, such as pulmonary edema, atelectasis, or chronic lung disease, these findings will not meet the pneumonia imaging requirement. And here's a screenshot of footnote number 2, which provides guidance about alternative imaging findings. When assessing imaging findings, we often see findings that are considered equivocal for infection. So what exactly do we mean by equivocal imaging findings? We mean that the imaging does not conclusively identify an infection or infectious process. In other words, the findings may be due to infection or they may not be due to infection. For example, you may see one of the following: infiltrate versus atelectasis, or opacity may represent pneumonia or congestive heart failure. So what do you do if the imaging findings are equivocal for pneumonia? If imaging is equivocal for pneumonia, there's a process for determining if the imaging is usable for meeting the imaging requirement. And this is covered in footnote number 14. When imaging findings are equivocal, you will first look to subsequent imaging for clarification. If the subsequent imaging findings are definitive for pneumonia, the equivocal imaging is eligible for use. If the subsequent findings no longer show pneumonia, the equivocal finding in the imaging is not eligible for use. But what if there are no subsequent imaging tests, or if subsequent imaging tests do not provide clarification? For example, the findings remain equivocal, or the findings become definitive but then go back to equivocal. In this situation, you would look for clinical correlation to clarify that the equivocal imaging findings are representative of pneumonia. For new, clinical correlation is specifically physician documentation of antimicrobial treatment for pneumonia. It is important to note that if the imaging findings are not eligible, the imaging requirement cannot be met even if there is clinical correlation. Clinical correlation can only be used with equivocal imaging. And here's a screenshot of footnote number 14, which covers equivocal findings. And as a reminder, we do have NHSN Chapter 16 that contains definitions for many key terms that are used throughout the NHSN surveillance definitions. I want to take a couple of minutes to talk about imaging reports, which are the radiologist's documentation of their review of the actual imaging tests. Imaging reports typically contain documentation of the findings, what the radiologist saw, and impressions, which is the radiologist's assessment of what the findings represent. This is the clinical documentation we review within the medical record to determine if the imaging element of the new definition is met. And we must consider the entirety of the imaging report, both the findings and the impressions, to make this determination. And while some imaging reports may clearly label the findings and impression sections in the report, we realize that not all imaging reports follow this format. Regardless of the format, you are looking for documentation within the report of what the radiologist saw and their impression of what it represents in that imaging test. I'll use the finding of opacity to demonstrate why we need to look at the whole imaging report. From a radiographic perspective, an opacity is defined as an area on the radiograph that appears more opaque than surrounding areas. Since many conditions can appear as opacities in a radiograph, we must also look at the radiologist's interpretation or impression of what the findings represent in that specific imaging test. For example, if the finding of opacity is documented to be consistent with infiltrates, which as per the pneumonia protocol is considered a definitive finding, we interpret this as representative of pneumonia and therefore an eligible imaging finding for new. If the finding is documented as representative of something other than pneumonia, such as pulmonary edema, this is not considered an eligible imaging finding for new. If the finding is documented as equivocal, in this example, atelectasis or pneumonia, we provide guidance in footnote number 14 on how to determine if the findings meet the new imaging requirement. And if there's no clarifying information about what the opacity represents, we provide guidance in footnote number 2 that if the opacity is not attributed to something other than pneumonia, then it can be interpreted as an eligible finding for new. When determining if the imaging element is met, remember the imaging test evidence is the same for all three algorithms, and the imaging requirement must be met in order for the new definition to be met. Determining if the imaging test results meet the imaging requirement is the most challenging part of the new surveillance definition. You can't just find one imaging test with a keyword and determine the imaging requirement is met. Unlike imaging for other NHSN events, the findings must be new or progressive, and they must be persistent. It is likely that a patient will have multiple imaging tests performed, and all temporally related imaging findings must be assessed to determine if the imaging requirement is met. And again, don't forget to apply your footnotes. Knowledge check number 2. Is the imaging requirement for new met with the following imaging test findings? On March 14th, the lungs are clear bilaterally. On March 15th, there are noted to be developing bibasilar and perihilar infiltrates. On March 18th, the perihilar infiltrates persist, and on March 20th, there are increasing bilateral infiltrates. Is the imaging requirement met? A, true, or B, false?
Jennifer, we are seeing overwhelmingly A's at this point.
Great job. Whoops, wrong direction. Great job. The answer is true. As you can see, on March 15th, there is a new definitive finding that are definitive from pneumonia, and these definitive findings persist in the subsequent imaging tests on March 18th and March 20th. Additionally, the definitive findings are also progressive in comparison to the prior imaging findings in March 20th. And knowledge check number 3. Is the imaging requirement for new met with the following imaging test findings? On March 2nd, there are increasing opacities noted in the imaging test. On March 3rd, the opacities are now noted to represent infiltrates versus pulmonary edema. On March 5th, the imaging shows worsening basilar opacities that reflect worsening pulmonary edema. And on March 6th, the imaging findings now report bibasilar pulmonary edema, and there is no additional imaging available. Do these imaging tests meet the requirement? A, true, or B, false?
Seeing a few A's, but mostly B's, Jennifer.
Excellent. The answer is B, false. In this scenario, the March 2nd imaging demonstrates a progressive finding of increasing opacities. And remember, as per footnote number 2, opacities can be considered eligible findings if not attributed to something other than pneumonia. But since persistence of eligible findings is also required to meet the imaging requirement, you would then look at subsequent imaging findings. And in this scenario, the 3-3 imaging findings are equivocal. The opacities are now documented that they may be due to infection or they may not be due to infection. As per footnote number 14, when imaging findings are equivocal, you must first look at subsequent imaging tests for clarification as to whether the equivocal findings represent pneumonia or a non-infectious process. The final imaging test on 3-6 now attributes the findings to a non-infectious process. Therefore, the imaging requirement is not met. Remember, opacities that are attributed to a non-infectious process are not eligible findings for meeting the imaging requirement. Now that we've covered the imaging component, let's talk about the signs and symptoms component. If you recall, New 1 has 3 different sets of criteria for signs and symptoms, and we'll look at these individually, starting with signs and symptoms for any patient, regardless of age. Remember, these criteria can be applied to any patient, so even infants and children can meet these criteria. The signs and symptoms requirement includes one of the following: a qualifying temperature, or leukopenia or leukocytosis, or for patients 70 years or older, altered mental status with no other recognized cause, plus 2 additional qualifying signs or symptoms. And these qualifying signs and symptoms must be from different bullets. So for example, if there's tachypnea and rales in the IWP, this would qualify as 2 additional signs and symptoms. But if there is dyspnea and tachypnea in the IWP, This would not meet the requirements since they are from the same bullet. The first alternative criteria is for infants less than or equal to 1 year of age. To meet this criteria, the infant must have worsening gas exchange and at least 3 additional signs and symptoms from different bullets. And the second alternative criteria is for a child from greater than 1 year to less than or equal to 12 years of age. To meet this criteria, the child must have at least 3 qualifying signs and symptoms from different bullets. The signs and symptoms criteria for new 2 requires one of the following: qualifying temperature, or leukopenia or leukocytosis, or for patients 70 years or older, altered mental status with no other recognized cause, plus at least 1 additional qualifying sign or symptom. And remember, the sign or symptom criteria applies to all patients meeting new 2, regardless of age. The sign symptoms criteria for new 3 requires that the patient must meet the new immunocompromised definition in footnote number 10, which we'll look at in a moment, plus at least 1 additional qualifying sign or symptom. Again, there are no age-specific signs or symptoms criteria for new 3. In order to apply the new 3 algorithm, the patient must meet at least one of the bullets in footnote number 10. If the immunocompromised definition is not met, you cannot apply the new 3 algorithm to that patient. There are a few more key points about the signs and symptoms elements that I want to highlight. First is that fever, leukopenia, and leukocytosis must meet the stated parameters in the protocol. And do note that the leukocytosis parameters are different for infants and children. Additionally, when meeting the breath sounds element, wheezing and rhonchi are only eligible to meet new 1 alternative criteria for infants less than or equal to 1 year old. Wheezing and rhonchi are not eligible for meeting new 1 for any patient, new 1 child, new 2, or new 3 signs and symptoms criteria. And again, don't forget about the footnotes. I want to specifically draw your attention to footnotes number 3 and number 5. Footnote number 3 addresses the requirements for purulent secretions. Purulent secretions must meet the parameters in the footnote. Secretions must contain at least 25 neutrophils and no more than 10 squamous epithelial cells per low power field, and these results can be found in the laboratory gram stain report. Clinical documentation of the descriptor purulent or purulence does not meet this criteria. Footnote number 5 addresses the requirements for tachypnea. There must be a documented respiratory rate that meets the age-based parameters in the footnote. Remember, when NHSN provides specific parameters for a value, you must apply the NHSN parameters and not your facility's parameters. Clinical documentation of tachypnea does not meet this criteria. There must be a documented respiratory rate that meets the parameters. Knowledge check number 4. The new 1 alternative criteria for infants less than or equal to 1 year old can be used with the new 2 and new 3 algorithms. A true or B false.
Few A's, Jennifer, but mostly B's.
And that is correct. The answer is B, false. The new 1 alternative criteria for infants less than or equal to 1 year old can only be used with the new 1 algorithm. New 2 and new 3 do not have age-specific sign or symptom criteria. Finally, let's look at laboratory test evidence for meeting new 2 and new 3. While there are several laboratory tests within the algorithms that can be used to meet the new definition, in this section, I will be highlighting the most commonly used laboratory elements. So please remember to refer to the algorithms in the protocol for a comprehensive list of available laboratory tests for meeting the new definition. The first step is to determine if the identified pathogen is eligible for use in meeting new. For the new definition, all Candida species or yeast not otherwise specified, all coagulase negative Staphylococcus species, and all Enterococcus species are excluded as pathogens unless identified from lung tissue or pleural fluid. If one of these pathogens is identified for blood, they can only be attributed as a secondary BSI pathogen to new if new2 or new3 is met with a matching organism isolated from lung tissue or pleural fluid, and the blood specimen is collected in the secondary BSI attribution period. The only exception to these pathogen exclusions is when meeting new3 for immunocompromised patients. In that situation, if there is a matching Candida species isolated from both a respiratory specimen and a blood specimen, and these two cultures can be used to meet the new3 definition, then Candida is an available pathogen. Otherwise, Candida is only an eligible pathogen when isolated from lung tissue or pleural fluid. So let's start looking at laboratory evidence from new2. The first laboratory element we'll review is organism identified from blood. If you have a blood specimen with an eligible organism for meeting new with a collection date in the new IWP, the eligible organisms in the blood can be used to meet the new definition, as long as the requirements in footnotes number 8 and number 13 are met. As per footnote number 8, the organism exclusions apply. So Enterococcus species, coagulase negative Staphylococcus species, and Candida species, and yeast not otherwise specified, identified from blood, cannot be used to meet this laboratory component. And footnote number 13 indicates that for blood specimens, results from both culture and non-culture based testing methods are eligible. Next is positive quantitative culture or corresponding semi-quantitative culture result from minimally contaminated lower respiratory tract or LRT specimens, which are specifically bronchoalveolar lavage or BAL, protected specimen brushing, or endotracheal aspirate specimens. As you can see, information from footnote number 9 is part of this laboratory element. In footnote number 9, the first bullet specifies that sputum and tracheal aspirate specimens collected from non-ventilated patients are not minimally contaminated and cannot be used to meet this laboratory element. Additionally, footnote number 9 directs you to table 5 for threshold values for growth of eligible pathogens on culture. Remember, the laboratory requirement is for a positive quantitative culture or corresponding semi-quantitative culture result. Table 5 provides the threshold values of quantitative growth on culture that must be met for the eligible specimen types. If these quantitative thresholds are not met, or the semi-quantitative equivalents are not met, then the culture result cannot be used to meet new. So for example, if the culture result is simply identifies an organism like E. coli, the laboratory requirement is not met. The culture result must specify an eligible quantity, such as greater than 100,000 CFUs per mil of E. coli from an endotracheal aspirate specimen, or an eligible semi-quantitative result, such as 4+ E. coli or many E. coli. Next, we'll look at organism identified from pleural fluid and positive quantitative culture or corresponding semi-quantitative culture result of lung tissue. Both refer you to footnote number 9 for the information in the second bullet. To remind you that Candida and yeast not otherwise specified, Enterococcus and coagulase negative Staphylococcus species are eligible organisms when identified from these specimens. Additionally, pleural fluid refers you to footnote number 13. Results from both culture and non-culture based testing methods are eligible for use. And lung tissue refers you to footnote number 9 and table 5 for the quantitative and semi-quantitative threshold value requirements for organism growth on culture. Additionally, both of these specimens have collection requirements that must be met for the specimen to be eligible for use. And these are specified in footnote number 9 for pleural fluid and in table 5 for lung tissue. And moving on to new 2, table 3. We often get questions about the first laboratory element, viruses, Bordetella, Legionella, Chlamydia, or mycoplasma identified from respiratory secretions or tissues. The organisms for this laboratory element can be identified by either culture or non-culture based testing methods. And nasopharyngeal or NP swab specimens are eligible specimens for meeting this laboratory requirement. Now let's look at new 3 and the identification of matching candidate species from blood specimen and respiratory specimen. In this specific laboratory element, sputum specimens and tracheal aspirates from non-ventilated patients are eligible. Again, there are footnotes that apply, the first of which is the immunocompromised definition in footnote number 10. Additionally, footnote number 11 specifies that both the blood and the respiratory specimen must be collected in the same IWP. And footnote number 12 indicates that a sputum specimen is an eligible specimen and that any quantity of candida identified is eligible. So table 5 requirements do not apply to this laboratory element. And footnote number 13 indicates that the organisms cannot be identified by either culture or non-culture based testing methods. Of note for this laboratory element, the requirement is for matching candida species. So this means that at least one of the specimens, either the blood specimen or the respiratory specimen, must have a candida organism identified. Under the laboratory column in new 3, you'll see or any of the following from laboratory criteria defined under new 2. What does this mean? It means that any of the laboratory criteria listed in the new 2 algorithm in tables 2 and 3 can be used to meet new 3 as well. But don't forget, the footnotes associated with the laboratory criteria also apply when meeting new 3. So for example, if you have Enterococcus faecalis identified from a blood specimen, it can't be used as an element in the IWP to meet new 3, since as we reviewed a few slides ago, footnote number 8 organism exclusions apply when using this laboratory criterion to meet new 2 or to meet new 3 using laboratory findings from new 2. Since the new definition is frequently used as a site-specific infection for secondary BSI assignment, let's look at some examples for correctly assigning a secondary BSI to new. As Latasha presented earlier, in order for a BSI to be determined as secondary to another site of infection, a site-specific definition, in this case new, must be met, and either secondary BSI scenario 1 or secondary BSI scenario 2 must also be met. Before we get started, a couple things to note. New 1 does not have a site-specific specimen or a blood specimen as a part of the criterion. Therefore, a BSI cannot be secondary to new 1. However, pathogens can be reported for new 2 and new 3 events, and therefore secondary BSIs can be attributed to new 2 and new 3 if the secondary BSI scenarios are met. Let's start with secondary BSI scenario 1. In this example, new 2 is met with E. coli identified from a BAL specimen. And note that many is an acceptable semi-quantitative culture result for meeting new 2. Additionally, there's a blood specimen collected in the secondary BSI attribution period, or SBAP, with a matching organism to the site-specific specimen used to meet new 2. new2 is met, and the BSI is secondary to new. In this example, new2 is met with both the Staphylococcus aureus and the Acinetobacter identified in the BAL specimen. Both organisms have semi-quantitative culture results that meet the requirements. The BSI organism matches at least one of the organisms in the site-specific specimen, Staphylococcus aureus, and therefore the BSI is attributed as secondary to new2. In this example, there is no matching organism, so the BSI cannot be determined secondary to new2. The determination in this case is that new2 is met with the organism identified from the BAL specimen, the Acinetobacter, but no secondary BSI is identified. And remember the excluded pathogens. What happens if they are identified in a blood specimen collected during the SBAP? Remember, if excluded pathogens are identified from blood, they can only be attributed as secondary to new if new2 or new3 is met with a matching organism identified from lung tissue or pleural fluid, and the blood specimen collection date is in the SBAP. Otherwise, pathogens excluded from the new definitions are also excluded as pathogens for BSIs secondary to new. This is covered in Chapter 2 in the Pathogen Assignment Guidance section. Instead, the excluded organism must be accounted for as either a secondary BSI to another site-specific infection or reported as a primary BSI. Let's look at an example. In this example, the matching E. coli in the blood specimen can be attributed as a secondary BSI pathogen, but the excluded organism, vancomycin-resistant enterococcus, or VRE, cannot. Instead, you will have to determine if the VRE can be attributed as a secondary pathogen to another site of infection or report it as a primary BSI. And in this case, the determination is new2 with a secondary BSI with only E. coli as the pathogen. In this example, VRE is identified from pleural fluid and new2 is met. Remember, enterococcus species are not excluded from new when identified from pleural fluid or lung tissue. And the BSI with a matching pathogen can be determined secondary to new2 in this scenario. Now let's move on to secondary BSI scenario 2. Remember, secondary BSI scenario 2 is met when an organism identified in the blood specimen is used as an element in the IWP to meet the new criterion. For new, there are two instances from the new2 and new3 algorithms in which blood can be used as an element to meet new. And as always, don't forget about the footnotes. This example is straightforward. A blood specimen with Staph aureus is collected within the IWP, and the organism is used as an element to meet new2. And the BSI is attributed as secondary to new2. In this example, the organism identified from the blood, Enterococcus faecalis, is an excluded pathogen, so the BSI cannot be secondary to new2. Now let's look at new3 for an immunocompromised patient. The blood and respiratory specimens have matching Candida species identified, and both specimens are collected within the IWP. So the Candida BSI can be attributed as secondary to new3. Another common scenario that occurs is when a blood specimen and a site-specific specimen both have collection dates in the IWP, but the pathogens do not match. Any BSI that is captured in the IWP is eligible for use in meeting the site-specific infection criterion and can be attributed to the site-specific infection as a secondary BSI, whether or not the BSI pathogen matches the pathogens from other specimens in the IWP that are also used to meet the site-specific definition. In this scenario, Nu2 can be met with a Staphylococcus aureus identified from the blood specimen with the collection date in the IWP. And Nu2 can also be met with E. coli identified from BAL specimen. Note that 4+ E. coli is an acceptable semi-quantitative culture result for meeting Nu2. And the determination is Nu2 with a secondary BSI, and both the E. coli and the Staphylococcus aureus are reported as pathogens for the event. Another common scenario that occurs is when Nu2 is met with an organism from a blood specimen, and there is a blood specimen with a matching organism with a collection date in the SBAP, but outside the IWP. If a BSI with a collection date within the new SBAP has at least one matching organism to the organism identified from the specimen, either the site-specific specimen or a blood specimen that was originally used to meet Nu, the BSI can be attributed as a secondary BSI. In this scenario, the blood specimen with E. coli is collected within the IWP, and the organism is used as an element to meet Nu2, and the BSI is attributed as secondary to Nu2. Additionally, there is a blood specimen collected in the SBAP with a matching organism to the organism in the specimen used to meet Nu2. And this BSI is also attributed as secondary to Nu. So what if Nu1 is met originally and there is a blood specimen with a collection date in the new SBAP? Remember, a BSI cannot be secondary to Nu1. Or what if Nu2 or Nu3 is met originally and there is a blood specimen collected in the new SBAP, but the pathogen doesn't match the site-specific pathogen? Remember that Nu1, Nu2, and Nu3 events all create a new RIT. And if Nu2 or Nu3 can be met within the new RIT using the blood specimen as an element in a new IWP, the BSI can be determined secondary to Nu. And let's look at a couple of examples. In this scenario, Nu1 is met originally, and the positive blood culture is collected outside the IWP. But remember, a BSI can't be secondary to Nu1. But if Nu2 can be met using the blood specimen as an element in the new IWP, and the date of event is in the new RIT, then the BSI can be attributed as secondary to the original Nu event. And in this example, Nu2 is met originally, and the positive blood culture is collected outside the IWP, but the organism does not match. But if Nu2 can be met using the blood specimen as an element in a new IWP, and the date of event is in the new RIT, then the BSI can be attributed as a secondary to the original Nu event. And we do have pneumonia FAQ on the FAQs webpage that does cover this situation. So please refer to that for additional guidance. Now that we've reviewed the new surveillance definition, I will turn the mic over to my colleague, Melissa Otis, who will be presenting the case studies portion of the presentation. Melissa?
Hi, Jennifer. Thanks so much, everyone. I'm excited to be here with you today. I just wanted to turn my camera on for a brief moment so you could kind of put a face with the name. I'm Melissa Otis, and I'm going to be doing the case study portion of this presentation. I am going to hop off of camera. Like I said, I just wanted to be able to put a face with the name, but I'm going to hop off during the presentation. And let's get started. Just of note, we will be using the Zoom polling feature during this portion of the presentation. So do be ready for that throughout the presentation. And then You will want to have probably a pen and paper handy, or maybe take some snapshots on maybe off of your cell phone or something like that. But there will be a lot of information presented that will help you make case determinations. So it will be helpful to have either something to take notes or snap a picture with. Next slide, please. Bear with me. Oh, thank you so much, Jennifer. So case number one, we have Mr. Brown. He's a 52-year-old man. He's admitted to the hospital. I'm so sorry. My screen has, there we go. He's admitted to the hospital on February 20th, 2024. That is an important note for later in the case, with upper gastrointestinal bleeding. He's admitted to the medical ICU due to hemodynamic instability. He has 2 central lines and a urinary catheter placed on February 20th. The patient's most recent previous hospitalization was in March of 2023. He has no recent surgeries. His medical history is significant for hypertension and alcoholism. The patient is afebrile on admission. He does have blood products and intravenous fluids are administered, and the upper endoscopy is performed on February 20th. Chest x-ray on admit shows his lungs are clear. I am going to give you just a moment on that slide so you can, like I said, take notes if you need to, or make any, snap any pictures that you may want to. All right, I think we're good to go ahead and probably move on, Jennifer. If you're okay with advancing, thank you so much. So just some additional case background on our patient then. We have this patient's blood pressure stabilizes on February 21st. He does remain afebrile. And then on February 23rd, the patient experiences copious hematemesis or vomiting of blood. He aspirates his gastric contents and develops respiratory distress. He is placed on a non-rebreather mask and maintains stable oxygenation overnight. And then a chest x-ray on February 23rd includes findings of an infiltrate in the right lung base. And I'll give you, again, just a moment on that slide so you can take any notes that you may want to. Okay, Jennifer, next slide, please. Let's jump into our first knowledge check. And as a reminder, we will be doing the Zoom polling feature. Is a chest x-ray performed on February 23rd eligible for use to meet a new definition? And your options are A, yes, B, no, or C, maybe. All right, and we're seeing the majority are coming in at yes, a few no's, and maybe just a few more maybes. So let's go ahead and take a look at our answer. Jennifer, if you could advance for me, thank you. The correct answer is maybe. I know there were a lot of yeses, but we do want to kind of take a look at why the answer would be maybe in this case. As a reminder, there was an eligible finding, yes, correct. However, the chest x-ray finding of infiltrate would need to remain, or an eligible finding would need to remain persistent in order to fully meet the imaging component of a new definition. Some additional case background. So we have this patient's admission continues. On February 24th, he does have a fever to 38.4 degrees Celsius at 5 a.m. He's developed a new cough. A chest x-ray at 6 a.m. shows infiltrates in the right lower lung field. Antibiotics are started. And then on February 24th at 8 a.m., so a little bit later that morning, he develops increasing shortness of breath. His O2 sats drop from 92 to 84% while on the non-rebreather mask. He is intubated and placed on mechanical ventilation at 8:45 a.m. And a chest x-ray done immediately after intubation shows worsening right lower lung or right lower lobe infiltrates. I'll give you just a moment on that slide again so you can take a peek if you need to, or take some notes if you need to. Oh, so sorry. Are you able to see my screen, Jennifer? I'm so sorry. I clicked the wrong button there.
Yes, we can see everything, Melissa.
Okay, perfect. All right, so go ahead and if you could advance there for me, Jennifer. And then on February 24th, we have urine, blood, and endotracheal aspirates that are collected. The urine culture is negative. We do have blood and endotracheal aspirate cultures that are positive for Enterococcus faecalis. On February 25th, the patient is febrile to 39 degrees Celsius and antibiotics are continued. On February 26th, the patient's maximum temperature is 37.9 degrees Celsius. Antibiotics are continued. A chest x-ray is performed and shows improved right lower lung infiltrate with atelectasis. And then on February 27th, the patient is afebrile and chest imaging shows stable right lower lung infiltrate. Again, I'll give you just a moment there if you need to take some notes. And we can go ahead probably and jump into our next knowledge check. Knowledge check 1B. Do the chest imaging results demonstrate new or worsening and persistent findings that are eligible to meet a new definition? And we're seeing the majority, excuse me, at yes. And the correct answer is yes. I'm sorry, I'm not sure what happened at the top of that slide. Became a bit jumbled there, but the correct answer is in fact yes. Remember, in order to meet the imaging element of a new definition, the findings must be persistent. So for any patient, regardless of underlying cardiac or pulmonary disease, you do need to look at all the temporally related subsequent imaging to ensure there is persistence demonstrated of any eligible findings. Let's go ahead and jump into our next knowledge check 1C. Are the blood culture and or endotracheal cultures eligible to use to meet the laboratory component of a new 2, or new 3 definition? Options are A, yes, or B, no. All right, and we're seeing a bit of a split on this one, but the majority are saying yes. The correct answer is actually no for this particular case. And let's talk about why that is. Enterococcus faecalis is an excluded organism for meeting the laboratory component of a new definition, unless it's identified from lung tissue or pleural fluid. If you look to the right of my screen here, you'll see an excerpt from general comment number 5 of chapter 6, which is the pneumonia protocol. Please note this information is also can also be found in the footnotes in 8 and 9 as well. Okay. What is the diagnostic test used to set an infection window period for this new event? Is it A, February 20th chest x-ray, B, February 23rd chest x-ray, C, the February 24th chest x-ray, Or D, the February 24th blood and endotracheal culture? And it looks like the majority are coming in at B, February 23rd chest x-ray. Great job, that is correct. Let's talk about why that is the case. The IWP is set using the collection date of the first positive diagnostic test that is used as an element to meet the site-specific infection criteria for which all elements of the new criterion occur within this IWP and sets the earliest date of event. In this particular case, we have a new chest imaging finding that is eligible for meeting a new definition on February 23rd, and therefore this will be used to set your IWP. Knowledge check 1E. So what is the new IWP in this case? We have option A, February 21st through 27th, B, February 20th, the 26th, C, February 22nd through the 28th, or D, February 19th through the 25th. And it looks like the majority are coming in at B, February 20th through the 26th. And Jennifer, do you want to go ahead? And there we go. Perfect. The correct answer is in fact B, so great job, everyone. The IWP is set by the February 23rd chest x-ray, which we talked about in the previous question, and then will be the 3 calendar days before and the 3 calendar days after that test. As a reminder, all elements of the criteria you are meeting must occur within this IWP. Knowledge check 1F. Is a new event, I apologize, met in this case? If so, what type of new event is met? Is it A, new 1, B, new 2, C, new 3, or D, there is no new event in this case? Give it just a moment here, see what responses we're getting in. EGs, are you able to project the response to this one? I'm not seeing it come up. All right, and it looks like the majority are coming in at new 1, with a few new 2s coming in there as well. And great job. That is in fact a new one. So let's talk about it. In this case, the Enterococcus faecalis found in the blood and the endotracheal specimens is not considered an eligible organism, and therefore not eligible for use to meet the laboratory component of new 2 or new 3. So a new 1 definition is our option, and the definition is met for any patient. With these elements, the elements are the new and persistent imaging test evidence of pneumonia that infiltrate that was first identified on February 23rd that does remain persistent, a fever greater than 38 degrees Celsius, and then there are 2 qualifying signs or symptoms from separate bullets of the bulleted list. There's a worsening gas exchange that's met when Mr. Brown transitions to a non-rebreather mask, and new onset cough and dyspnea is also met. It is important to mention that the new onset of cough and dyspnea does come from the same bullet in the new 1 definition. Therefore, this qualifies as only 1 sign or symptom. Now let's check 1G. We're moving right along here. What is the date of event? Is it February 22nd, February 23rd, February 24th, or February 25th? And then Courtney, whenever you see We're getting the majority in. Perfect. Oh, looks like this one was overwhelmingly, we got B, February 23rd in that particular case. So great job, everyone. That is correct. The date of event is set by the first element used to meet an NHSN site-specific definition. In this case, we're meeting a new or new one definition. And it's when this occurs for the first time in the 7-day infection window period. In this case, Mr. Brown's worsening gas exchange, the respiratory distress with transition to a non-rebreather mask does occur on February 23rd, and this will set our date of event. And this will be our final question for this particular case, and then we'll jump into another one. So case number 1, knowledge check 1H. What is the repeat infection timeframe, or RIT? Just a reminder, I know I mentioned this in the beginning, but it is important to note that this event occurs in 2024. So February does have 29 days. And the options are A, your RIT is 220 through 3/4. B, your RIT is 221 through 3/5. C, of 222 through 3/6, or D, 223 through 3/7. And the correct answer, well, actually, before I give the correct answer, let me look at what you answered. It looks like the majority answered option D. So great job, everyone. You are absolutely correct. Option D is the correct answer. As a reminder, the repeat infection timeframe is that 14-day timeframe during which no new infections of the same type are reported. The date of event is day 1 of the 14-day RIT. And if criteria for the same type of infection are met, and the date of event is within that 14-day RIT, a new event is not identified or reported. Therefore, a new 1, new 2, or new 3 definition is met within this RIT, it would not be reported. In this case, the date of event is 223, and therefore, because it's a leap year, your RIT would run 223 through 3/7. So great job, everyone. Are you ready to jump into case number 2? Here we go. We have Miss Fall. Miss Fall was admitted following a head injury from a fall at home on 9/17. On 9/20, she had a chest x-ray that showed stable infiltrates, and the same thing on 9/21. Following that on 9/22, she had a chest x-ray that showed moderate coarse bilateral pulmonary infiltrates that are similar to or slightly improved from the prior study. On 9/24, she had a fever. On 9/26, she had another chest x-ray that showed increased diffuse bilateral pulmonary infiltrates that are noted that are slightly progressed from the prior study. On 9/26, she had a white blood cell count of 16.4, and 9/26, she was also intubated due to declining respiratory status and desaturations. I'll give you just a moment on this slide again in case you want to take any notes or snap a quick picture so you can reference back to this information. Seeing a few thumbs up coming through, letting me know, I'm thinking that you're letting me know that you have gotten what you need to. So we'll go ahead and move on to the next slide, some additional background on this patient. On 9/27, we have another chest x-ray. This time there's diffuse pulmonary infiltrates without significant interval change. On 9/27, we have an endotracheal aspirate culture. The results are moderate growth of Enterobacter cloacae. On 9/28, we have a chest x-ray showing stable bilateral infiltrates. 9/28, we also have a white blood cell count of 19.7. And 9/29, we have a chest x-ray that shows when compared with the prior study on 9/28, there's been interval worsening of the bilateral diffuse patchy infiltrates. Again, I'll give you just a moment to take some notes if you want to. If you don't mind shooting me a thumbs up when you have gotten the information, when I see quite a few of those come through, then we'll go ahead and move on. Okay, seeing lots of thumbs up come through, so we'll go ahead and move on to our first knowledge check. Do the chest imaging results demonstrate new or worsening and persistent findings that are eligible to meet a new definition? Options are A, yes, B, no, C, maybe. Overwhelmingly, we are seeing at 92%, we are seeing yes. And that is the correct answer. In this case, Ms. Fall does have worsening eligible findings for meeting a new definition identified on the 926 chest x-ray with an increasing or worsening infiltrate. In addition, this eligible finding does remain persistent on 927 and 928 and also 929. Please note, if there were any additional imaging findings available after this 929 imaging test, these findings would need to remain persistent with those imaging tests as well. You would want to review all temporally related imaging findings to ensure there's not rapid clearing or attribution of the findings to a cause other than pneumonia. Let's move on to knowledge check 2B. Which diagnostic test would be used to set an IWP? Is it A, the 923 chest x-ray, B, the 926 chest x-ray, C, the 927 endotracheal aspirate, or D, the 929 chest x-ray? Okay, and it looks like we are seeing the majority come in at B, with 82% of you saying the chest x-ray at 926, and that is correct. The imaging findings up until the 926 chest x-ray are eligible and persistent, but they don't show any new or worsening, and therefore wouldn't be eligible to use to set your IWP. Since the 926 imaging test has worsening eligible findings, this is the first diagnostic test used to set your IWP. Great job, everyone. Knowledge check 2C. What is the new IWP set by this imaging test? Is it 922 through 928? That's option A. B is 923 through 929, or C, 924 through 930. You guys are doing great. Looks like 88% of you said option B, 923 through 929. And that is the correct answer. We've already determined that the IWP would be set using this 926 chest x-ray, so that our IWP would be that 3 calendar days before and 3 calendar days after, so 923 to 929. Now let's check 2D. Is the endotracheal aspirate eligible for use to meet a laboratory component, or to meet the laboratory component, I apologize, of a new definition? As a reminder, this is our finding. We have a 927 endotracheal aspirate culture results showing moderate growth of Enterobacter cloacae. Options are A, yes, or B, no. And overwhelmingly, again, with 81%, we're seeing yes. Great job, everyone. That was the correct answer. Because this patient is intubated, this specimen is an endotracheal aspirate and therefore is an eligible respiratory specimen. Looking at the right of my screen, you're going to see here table 5. This is a table you'll want to reference to ensure that eligible respiratory specimens meet the appropriate quantitative values. In this particular case, however, there is no quantitative value, but there is a semi-quantitative value of moderate growth. As you can see in the highlighted footnote, semi-quantitative values are eligible for use if they meet the requirements noted here. In this case, a moderate growth is considered an eligible corresponding semi-quantitative result, and therefore it's an eligible finding. Knowledge check 2E. Is there an eligible new event in this case? And if so, what definition is met? Your options are A, new 1, B, new 2, C, new 3, or D, there is no new event. And overwhelmingly, we are seeing new 2 come through as the majority, or 84% of you are saying new 2, and that is in fact the correct answer. So let's take a look at the rationale behind that. We can meet a new 2 definition using the worsening and persistent eligible findings that infiltrate. We already talked about the eligibility of those imaging findings. We have signs or symptoms. We have fever and leukocytosis. Either fever or leukocytosis are eligible findings. Please note, however, both are not required. In addition, the patient has worsening gas exchange. In this case, the patient's intubated. And we do have eligible laboratory findings at endotracheal aspirate with qualifying semi-quantitative values. All of these elements are captured in the new or new 2 IWP, and therefore we have a new 2 event. So what is the date of event for this event? Is it 9/23, 9/24, 9/25, or 9/26? We're seeing a little bit more of a split on this one. We're seeing some 9/24, a few just below that, we're seeing 9/26. The 52% are saying 9/24 and 33% are saying 9/26. The correct answer is actually what the majority are saying, which is the 9/24. As a reminder, the date of event is the date the first element is used to meet the NHSN site-specific infection criteria, occurs for the first time within the 7-day infection window period. In this case, the fever documented on 9/24 does set your date of event. All right, hopefully you guys can hang with me through one more case study. This is our final case study of this session. So let's jump into case study number 3. All right, we have Mr. Opacity. He's a 38-year-old male with a history of HIV. His last CD4 count was 180. He's admitted from the emergency department following a motor vehicle accident on April 6th. He has no other chronic health conditions, and in the ED, a urinary catheter and right subclavian catheter are inserted. He's taken directly from the ED to the operating room, where several operative procedures are performed, including an NHSN qualifying open reduction of a fracture and a craniotomy. Chest X-ray on admission does show clear lungs. And I'll give you just a moment in case you want to take any notes on this slide or snap a picture. All right, some additional case background on this patient. We have on 4/9, the patient has a temperature of 37.4 degrees Celsius. On 4/10, his white blood cell count increases to 17.2. He has a temperature of 37.0 degrees Celsius, and chest X-ray shows multiple opacities consistent with pneumonia bilaterally. Blood and urine cultures are collected in addition to an endotracheal aspirate. In addition, he has severe respiratory decline and is intubated. On 4/11, his temperature is 37.2 degrees Celsius. He does have some preliminary blood culture results come back that show yeast and antimicrobials are initiated. He does have a chest X-ray that shows stable bilateral opacities consistent with pneumonia. And then on 4/12, the final blood culture results do come back showing Candida albicans and an endotracheal aspirate culture showing Candida species. Rhonchi are also auscultated on physical exam. He has a chest x-ray that shows slightly improved opacities consistent with pneumonia bilaterally. On 4/13 through 4/15, the patient remains stable. On 4/16, the patient is afebrile and the vent is discontinued. Give you just a moment there in case you want to take any additional notes. If you don't mind throwing some thumbs up in there when you are ready for us to move to the next slide. All right, let's jump into our first knowledge check for this final case study. Do the chest imaging results demonstrate new or worsening and persistent findings that are eligible to meet a new definition? Your options are A, yes, B, no, or C, maybe. And overwhelmingly, it looks like 82% are saying yes, with 13 at no and 4% saying maybe. Great job, everyone. The correct answer is in fact A, yes. The opacities noted on the 410 chest x-ray are not attributed to something other than pneumonia, and therefore this finding is a new eligible finding. Reminder, they were clear, his lungs were clear on admission. So it's a new eligible finding for use to meet a new definition. In addition, this finding does remain persistent and the opacities continue to not be attributed to something other than pneumonia on 4/11 and 4/12. As I noted in the previous case, if additional imaging test findings were available for this patient, you would need to ensure that the persistence is still demonstrated in any further imaging test findings and that the opacities continue to not be attributed to something other than pneumonia. Let's jump into knowledge check 3B. Are the blood culture and or endotracheal cultures eligible for use to meet the laboratory component of new 2, or new 3? Options are A, yes, B, no, C, maybe. And it looks like about 61% are saying yes. We've got 19 at no and about 20% saying maybe. And the correct answer is C, maybe. If you look to the right of my screen, you can see that matching Candida species identified from blood and respiratory specimens with collection dates and the same IWP can be considered for use in meeting a new or new 3 definition. In this case, if the patient meets a new immunocompromised definition. And so you can see that this referenced in general comment 6 and footnote number 9. So let's look at our next question, which will help us make that determination. Does the patient meet an immunocompromised definition? Is it A, yes, or B, no? And the correct answer is A, yes, which looks like the majority of you have said. NHSN does offer an immunocompromised definition in footnote number 10 of chapter 6. In this case, Mr. Opacity meets bullet number 2 with his most recent CD4 count of 180, which is less than the requirement of 200. And you can see that highlighted there on the right of the screen, the criteria and the bullet that he meets within that definition. Knowledge check 3D. Are the organisms identified in the blood and endotracheal aspirate considered matching? Your options are A, yes, or B, no. Like 92% of you are saying yes, and just a few, about 8% are saying no. Great job, everyone. The correct answer is yes. In this case, the Candida albicans in the blood is considered matching to the Candida species in the endotracheal aspirate, as per the matching organism guidance found in chapter 2 and chapter 4 of the patient safety manual. In this case, they match at the genus level. I will also note in order to be eligible to meet a new 3 definition, at least one of the specimens must have Canada identified. Let's move on to knowledge check 3E. Which diagnostic test would be used to set a new IWP? Is it A, the 4-6 chest x-ray, B, the 4-10 chest x-ray, C, the 4-11 chest x-ray, D, the 4-10 chest x-ray and blood culture, or E, the 4-10 chest x-ray, blood culture, and endotracheal aspirate? Well, it looks like the majority are coming through at 48% are saying it's the 4-10 chest x-ray. And then we've got about 38% that are just below that are saying the chest x-ray, blood culture, and endotracheal aspirate. And that is in fact the correct answer. Option E. In this case, the imaging test, the blood culture, and the endotracheal aspirate cultures were all collected on 410, and all of these are eligible for use to set a new IWP. As a reminder, the IWP would be the 3 days before, the 3 days after that 410, and all elements of the new definition must be met in this window. Therefore, your new IWP would be 4-7 through 4-13. Knowledge check 3F. What is the eligible sign or symptom for this case that can be used to meet the new 3 definition? Is it A, leukocytosis, B, fever, C, worsening gas exchange, or D, bronchi? And it looks like 48% are saying it's the worsening gas exchange, about 36% are saying the leukocytosis, and then a few coming in with the fever and the bronchi. And the correct answer is C. It is our worsening gas exchange. In this case, the worsening gas exchange that occurs with the respiratory decline and subsequent intubation is the only eligible sign or symptom in this case. Fever is not eligible as the patient maximum temperature never reaches the NHSN definition of fever, which is greater than 38 degrees Celsius. Leukocytosis is not an eligible sign or symptom for meeting a new 3 definition. And then finally, bronchi is not an eligible sign or symptom for meeting a new 2 or new 3 definition. All right, let's move along to knowledge check 3G. Is there an eligible new event in this case? And if so, what new definition is met? We have option A, new 1, B, new 2, C, new 3, or D, there is no new event. And overwhelmingly, it looks like 89% are saying new 3. Great job, everyone. That is the correct answer. There is a new or new 3 event in this particular case. So we do have matching blood and respiratory laboratory specimens with matching Canada species collected in the same IWP. The patient does meet the immunocompromised definition. Remember that CD4 count. And then in addition, the patient has new or eligible imaging findings that remain persistent and an eligible sign or symptom, that worsening gas exchange. So all the criteria are met in our IWP, and therefore we meet a new 3 definition. Let's move on to knowledge check 3H. What is the date of event? Is it 4-6, 4-7, 4-9, 4-10? And we've got 86% saying that it's 4-10. And then just a few coming in at 4-6, 4-7, and 4-9. Great job, everyone. 4-10 is the correct answer. In this case, we have several elements that are used to set the date of event as they all occur on the same day. The blood and endotracheal aspirate cultures collected on 4/10, as well as worsening gas exchange or that intubation on the same day, set our new 3 date of event as 4/10. All right, well, this concludes our pneumonia presentation for today.